Hello students, welcome to the channel Paediatrics Next by Dr. Ashutosh Aggarwal, and today in this session we'll be discussing some of the MCQs related to the pediatrics neurological disorder. These MCQs are just for the practice purpose. So if we start with the first question, the first question says there is a 9-year-old girl where there is onset of uncontrolled movements of the hands and emotional changes. The movements disappear during sleep. She is healthy and is not taking any medication. Which of the following will be relevant? Right. So whenever you get the clinical based question, conceptual questions, you should always follow the method of exclusion. Now 9-year-old child definitely can have medulloblastoma. This medulloblastoma in this arises from cerebellum. So this usually presents with the hydrocephalus. Medulloblastoma causing uncontrolled movements which disappear during sleep, that is unlikely, which is there is, plus there is also the emotional changes which are present. So this rules out that this is not medulloblastoma. Similarly, if we consider hydrocephalus, now hydrocephalus in this child will present with other features that will not present with these seizure kind of the movements. So this is particularly ruled out. Now in this, one choice is being given evidence of streptococcal infection. So if they are giving you this choice, that means you can think of Sydenham's chorea, which is one of the major Jones criteria of the rheumatic fever. And the another is EEG to rule out the partial complex epilepsy. Now if you see the movements disappear during sleep, and the chorea movements are like this only. Chorea movements are involuntary movements. They are present when the child is awake, they disappear during sleep. And what is being given is child is not taking any medications. So if it has to be epilepsy, that means child might be taking any medications, and these medications overdosage can result in the uncontrolled movements, right? But the child is not taking medication, so this particularly rules out the partial complex epilepsy. So out of this, the most appropriate answer is evidence of the streptococcal infection, as this might be the case of the Sydenham's chorea. Now one can say that Sydenham's chorea, when you diagnose at the major Jones criteria, it is only sufficient to diagnose, right? The same is there. But out of the 4 here, what the choices are given, we are choosing the most appropriate one. So the most appropriate out of the 4 goes in favor of the evidence of the streptococcal infection is. Moving on to the next question, Dandy-Walker malformation of the following can be seen except. Now when we particularly talk of the hydrocephalus, there are 2 conditions which are particularly the causes of congenital hydrocephalus. Although there is aqueductal stenosis that also can cause congenital hydrocephalus, but Dandy-Walker and Arnold-Chiari malformation. So if you see here, we are showing is the normal brain, and if you concentrate here, this is the 4th ventricle, cerebellum and the brainstem is. And if you particularly concentrate on this area in the Dandy-Walker syndrome, there is particularly a cyst, and this is a posterior fossa cyst which communicates with the 4th ventricle, and there is the abnormally formed cerebellum. So this triad actually forms is the Dandy-Walker syndrome, is a posterior fossa cyst and last 4th ventricle and a abnormally formed cerebellum. So if you particularly see here, will there be enlargement of posterior fossa? Yes, there will be enlargement. Will there be dilation of the 4th ventricle? Yes. Will there be hypoplasia of cerebellar vermis? Yes. But herniation of the cerebellar tonsils through the foramen magnum. This is something which is seen in the Arnold-Chiari malformation. So that is seen in the Arnold-Chiari malformation. It is not a feature of Dandy-Walker. So except they have asked here, so the right answer goes in favor of here. Herniation of cerebellar tonsil is the except choice. 6-year-old male child, history of progressive muscle weakness. On examination, there is bilateral calf enlargement. When he is asked to stand from the seated position, he supports the thigh. Serum creatinine kinase is increased. Now, if you just instantaneously you all be able to make the diagnosis, we are talking here of the Duchene muscular dystrophy. We are talking here is the Duchene muscular dystrophy, right? Now, Duchenne muscular dystrophy, the mode of inheritance is X-linked recessive. So that is mainly seen in males. So here it is being given is the male case. Then the child has progressive muscle weakness, and all muscular dystrophies are basically progressive. And in Duchenne muscular dystrophy, there is bilateral calf enlargement, pseudo hypertrophy of the calf muscle is seen. And when he is asked to stand from the seated position, he supports the thigh. You are talking of here the Gower sign, and this is particularly the Gower signs. The child is asking to basically stand, but at this time he is supporting the thigh. So this is the Gower sign. And Duchenne muscular dystrophy, there is involvement of the proximal muscles. So there is involvement of the proximal muscles of the lower limbs also. So where there is the Gower sign is positive. Gower sign is positive, right? So if you see here, a child comes progressive muscle weakness. What is the initial screening test to be done? Serum creatinine kinase. And if the creatinine kinase comes out to be increased, the next test to be done now is the genetic analysis of the dystrophic gene, because the most common mutation here is the deletion which is seen, and the second is duplication. So basically, if the creatinine kinase is increased, now you go for the genetic analysis of the dystrophin gene. Moving on to the next question. There is a 4-year-old boy with history of 2 days, fever of 2 days, which comes with history of convulsions lasting for 10 minutes. So there is a history of seizure, which is along with the fever, right? That is there. Age group is 4 years. He is now alert and responding well. Out of the following to be done is. Now, fever along with the seizure, no other symptoms being given, no other signs being given, age is 4 years. It is most likely a case of the febrile seizures. It is most likely a case of the febrile seizure. The febrile seizure, the age is 6 to 60 months. The age group is 6 to 60 months. This is a 4-year-old child, very well in the age group, 6 to 60 months. And there is seizure which is associated with rate of change of temperature. Now, if you go for the duration, that is 10 minutes. And if it is less than 15 minutes, this basically means is the simple febrile seizure. Simple febrile seizure. Right? And in simple febrile seizure, what is important to remember? No prophylaxis is needed. No prophylaxis is needed, right? You are not giving intermittent prophylaxis in the simple febrile seizure. EEG and MRI both are not indicated in simple febrile seizure. So this is also wrong, and seizure duration of 10 minutes is qualified under simple febrile seizure. So out of the 4 being given, the most appropriate right answer is no prophylaxis is needed here. Moving on to the last one. 18 months old girl has a 10-minute long generalized seizure associated with temperature of 40 degree. Following factor in the history is most likely to increase the risk of the future seizure. Now basically in the febrile seizure, what is important that they are recurrent. Next time the child gets fever, there are more chances of recurrence of febrile seizure. And you need to remember what are the major risk factors which are associated with recurrence, what are the minor risk factors which are associated with recurrence. Major risk factor is onset in infancy. Onset in infancy. Febrile seizure on day 1 of fever. Febrile seizure on day 1 of fever, and temperature is 38 to 39, right? So this is basically what we say is the major risk factors of particularly the febrile seizures, right? So this is only what you need to remember here is if there is febrile seizure in first year of life, if there is febrile seizure in the first day of fever, they both are the major risk factors. Minor risk factors includes is family history of febrile seizure, family history of epilepsy. This is male gender. Male gender. It is low serum sodium. Low serum sodium, and this is complex febrile seizure. Complex febrile seizure. So going according to this, Apgar carries no significance here. Female gender, no, it should be male gender. Onset in second year of life, no. Onset in the first year of life is. And family history of epilepsy, that is particularly the factor which is going to increase the risk of future febrile seizures. So just I want to give you a practice of solving the MCQs. So I will try to post more of the videos regularly. That is there. Do watch the videos. Any doubts, you are most welcome. You can ask the questions. Thanks for watching.